Hi guys, today I'm going to be talking about my research case study, which is primarily talking about the temporomandibular joint disorder. We're just going to do a quick recap on the two sources that my research study is based on. The first source was about the short-term effects of dry needling of active myofascial trigger points in the masseter muscle in patients with temporomandibular disorders, which was by Fernandez Carneiro et al. In 2010. This article's aim was to reduce TMJD pain and increase the subject's maximal jaw opening without pain by using myofascial dry needling. The article had two groups. They had a sham dry needling group, which they only penetrated the skin, and then they had a myofascial dry needling group. They dry needled the masseter's active trigger points where they wanted to achieve at least 5 local twitch responses. They used an electronic algometer to measure the pressure pain threshold to the point where the subject's sense of pressure turned to pain. They measured the maximal mouth opening by the distance between the upper and lower central dental incisors, which was measured in millimeters. The subject received two treatments at least 7 days apart. The maximal jaw opening increased. The pain pressure threshold increased over the masseter muscle also. This study has demonstrated that the dry needling of the active trigger points within the masseter muscle induced more significant increases in the pain pressure threshold and in the degree of pain-free maximal jaw opening when compared to sham dry needling. The secondary source of information was from the myotherapy treatment and assessment subject, which is being taught at RMIT University in the Advanced Diploma of Myotherapy, which was by Casey Gibson, J. Davies, and R. Granter in 2014. This source spoke about TMJ-related headaches. It stated that they may be present with other symptoms such as tooth pain, ear pain, ringing in the ear, eye or orbit pain, and jaw clicking and locking. They use a 3-knuckle test pre and post treatment. The manual technique used is digital ischemic pressure, also known as DIP, and myofascial tension technique, which is also known as MFTT, and that is used with active movement to the temporalis and masseter muscles. So now that we've done a little recap on my primary and secondary source, we're going to speak about my research case study. With my study, I had two groups of 5 subjects in each group. Group A received the myofascial dry needling in the masseter muscle for 10 minutes, followed by active movement of the TMJ. Group B received the DIP and MFTT with active movement to the masseter muscle and temporalis muscle. Both groups received 2 treatments in total, with a minimum of 7 days in between each treatment. Each individual was given a 7-day diary after each treatment, which involved answering questions such as, where is the pain and how bad is the pain out of a 10? Do you have headaches? How frequent are they? Where is the pain? How is the pain out of 10? Sleeping pattern. Are they having a comfortable sleep? Is it easier to sleep or do you feel better when you wake up? We do an AM, midday and PM. So that will include a pain scale, a headache, and how did you sleep for the AM. Now I'm just going to show you guys a few photos and videos of the techniques that I used throughout this research study. In the first photo, it shows MFTT being done on the masseter muscle. The next video clip is going to show the MFTT with active movement of the temporalis muscle. The next two photos are going to show the DIP of the masseter and temporalis muscle, where we stayed under a 7 out of 10 for pain. The next photo is going to show the dry needling of the masseter muscle. This is going to be followed by the active stretch that we do post needling treatment, where we pin the masseter muscle just under the zygomatic arch and ask the client to open their mouth as far as they can without any pain. And this last photo is going to show how to do the 3-knuckle test with your non-dominant hand. In this table, it shows the results of MFTT and DIP of the masseter and temporalis muscles. On the far left-hand side, it shows the 5 subjects with their 3 consultations, labelled as Day 1, Day 5, and Day 15. With these results, you can see that all outcomes are positive, with either a decrease in pain over 15 days, a decrease in headaches, an increase in the 3-knuckle test, and you can also see that no client was able to get 3 knuckles in their mouth prior to the first treatment, but were able to get it after the 2 treatments. In this table, it shows the results of dry needling the masseter muscle followed by active stretching. It's the same as the other table, where on the far left hand side it shows the 5 subjects with their 3 consultations labelled as Day 1, Day 5 and Day 15. With these results, you can also see that only one subject could get the 3 knuckles while the rest couldn't. Headaches have decreased in all subjects who had them, and by Day 15 headaches were to a minimum, everyone had 3 knuckles and pain had decreased. When comparing my dry needling group to my primary source, which was sham dry needling versus dry needling, we had similar results such as the maximal jaw opening had increased while being pain-free, and the pain had decreased after 15 days. And when comparing my MFTT and DIP group, it showed that TMJ may refer into the ear or come across as a toothache. It also used the 3-knuckle test pre and post treatment and spoke about TMJ related headaches. One of the 2 main issues that I had with this case study was the dry needling. Trying to convince the subject that dry needling to the masseter muscle is safe, very specific, and can have many benefits was a bit of a struggle. If someone else repeated this research study, it would probably be beneficial to show the subjects the muscle on an iPad app or the internet and explain to them where all the major structures are and how you're going to safely needle them. You could also make a brochure to show the benefits of getting a masseter dry needled. The last issue was that it was a bit of a struggle for the subjects to fill in the 7-day diary. It was a bit hard for them to keep it on them in the morning, afternoon and at night, so they weren't always filling it in as accurately as they could. By implementing one average pain scale for the day instead of 3, it could probably make it a bit more easier for the subjects to fill them out and more accurate results. Overall, I think that my classmates should try both techniques, and if one technique has no results after about 2 treatments, then maybe trying the other technique would be an option. It will mainly depend on how comfortable the client is with the needles, but it also depends on what the client is presenting with. That's the end of my presentation for my research case study. I hope you all enjoyed it. Thank you.